Okay, now the fun stuff. It's my pleasure to introduce our three speakers today. We have Mike Crosby, Elena Memoracion, and Colleen Slattery with us today. Mike is a corporate investigator for corporate security. Mike Crosby has been with Northwell Health Corporate Security since October of 2011. Prior to coming to Northwell, he was an investigator for the New York State Department of Health, Office of Medicaid, Inspector General, Bureau of Investigations and Enforcement. Mike is retired from the NYPD, where he held various assignments. He holds a bachelor's degree from St. John's and a master's from Adelphi. Elena has many years of progressive nursing leadership roles. As the senior director of PCS, she provides leadership, strategic direction, and operation of inpatient care units and multi-site dialysis programs serving 6 hospitals. She leads the hospital's Nursing Quality Council, Professional Practice Council, and RN Peer Review Committee. She holds a DNP degree in nursing leadership from Case Western Reserve University and MSN in nursing administration from Adelphi University. She is board certified in nursing executive advanced, a fellow of American College of Healthcare Executives, and certified professional in healthcare quality. Colleen Slattery earned her bachelor's of pharmacy degree from St. John's. She is currently the senior manager of pharmacy at North University Manhasset. She has held various positions in North Shore Elijah Health System. She started her career as a staff pharmacist and has also served as a renal transplant pharmacist for 4 years. In her position as senior manager, she has completed several Six Sigma certificate programs and oversees the daily operations of the pharmacy department. She is responsible for the hospital's drug diversion monitoring. She also works to streamline the medication reconciliation process and promotes a culture of patient safety while facilitating safe and cost-effective pharmaceutical care. It's my pleasure now to hand it off to Mike to kick us off.
Maybe thank you. Folks, thank you for taking the time out to listen to what I think is a real important topic. Yeah, a little bit about my background. I worked for the Bureau of Investigations at the Department of Health, and that was pretty much an eye-opener. I was used to, the illegal narcotics, and now I'm totally seeing a different side. So it was definitely a big learning curve for me. And, hopefully from this presentation, hopefully you can take something away with it that will be able to help you in your careers. So go ahead. Again. Basically, what I'm going to talk about is substance use disorder and drug diversion, and just the awareness of it. Northwell gives me the opportunity once a year. I go down to the conference for the Association for Drug Diversion Investigators, and what we're seeing in the health system here is exactly what every other health system in the United States is seeing. The opioid epidemic, as you know, you read about it every day. Fentanyl's in the paper. It's just we're trying to stay one step ahead of it, and from the relationships we have with the DEA and the New York State Department of Health, the B&E, they feel like we're one step ahead of it, but we can't relax. We got to keep the foot on the pedal and make everyone aware of what's happening. So, folks, drug diversion, when you peel that down, it's a theft. It's a theft. And a lot of times, because we're in a hospital setting, it would be considered, and I'm going to be talking criminality terms here. It's a penitent larceny, misdemeanor maybe. But what's going to happen is, as soon as someone takes that narcotic from that Pyxis or the Acudose and the Omnicell, you're falsifying a business record, and that's a felony. All right, so right away, and depending on the circumstance, if there's a victim impact, it could very well jump to an assault. So and we just try to stay ahead of it. So as I said, these are some of the articles that I just pick up just about every other day. I'm looking in articles through DEA, and some of the fines that health systems get, like you can see this one, 4.36 million. There was one just in Chicago, over 2 million for narcotics that go missing. So we try to stay on top of it. One of the nice things here, we work with EAP, and they're a big benefit to have. And not only are our teammates eligible for that, but our family members are. All right, because it's not just the healthcare that gets affected. Everybody.
I see one right there.
Go again. All right. So what we're looking before COVID, we were looking at probably 1 in 10 healthcare workers. Now we're looking at probably 12 to 15%. But you do the math. Northwell Health has over 85,000 employees, so it's a pretty big task. And we do monitor, and we try to keep on track of what's going on, the trends, and what we've seen going through the different health systems. All right, who can divert drugs? Anyone can. Anyone can. I'm having trouble with that word today. Anyone can divert drugs. All right, it's not just people. It's not just the healthcare professional that has access to that. To the Pyxis. If there's a way, somebody will try to break into it. Someone will try to swap meds, whether it's at Pyxis, whether it's at bedside. They're going to find their way. If they want it, they're going to find a way. So what we try to do, we do try to monitor. We try to keep on, keep our ears open to hearing what's out there. Part of the reason I'm here today is our staff also can be the eyes and the ears to help us. All right. Anyone who is diverting, we had seen majority of them, it's for personal use. Okay, people are struggling, and everyone worked very hard to get their license. We all made that good choice, and you don't realize it. It takes one simple tweak of the back, lifting a patient, to get you on that road to where you could possibly end up, being dependent, upon a narcotic. All right, so, and it doesn't happen. It may not go noticeable right away, and it may take us a couple of months, but you know what? Unconsciously, that one then turns into two, that two turns into three. You don't even realize what's happening, and next thing you know, you're struggling. Okay, how do we know you're struggling? Well, we'll go ahead. We'll show. We have ways, and what we're seeing. Remember, I told you that tweak of the back. Now, combine that with some of the stresses I have up here, the home troubles. You don't realize it. You're bringing in a divorce, you're bringing in a death in a family, a sick child. All that adds up. And you may not be aware of it, but next thing you know, you're dealing with a heavy patient volume. You're dealing with, the long hours, short staffing. You work in the holidays a lot, at weekends where you're short staffed. Right? This all plays into it. And like I said, that one then becomes a two. You don't even realize it. And then we start seeing it, okay? So what we see is we monitor. We're going to see how many frequent trips you're making to the restroom, how many times you're going into the garage, okay? Everything today is a card access swipe, or, we have our ways of finding out. Go ahead, Ruben. So we see the frequent waste, okay? We see, we see a lot up there. We see the patient complaints coming in, okay? We see that great employee that always comes in early, leaves late, is volunteering to help somebody out. Oh, I'll medicate your person while you go on break. We see that. Okay? And the reason I'm telling you is we're hiding nothing. There's nothing to hide here. So what I'm saying is, if you're seeing someone struggle, get that person a self-report. All right, have them get to EAP, because we would rather that. Because the longer it goes on, the harder it is for that person to recover. Okay, and if they do eventually get investigated by B&E or the DEA, they're going to have a lot of explaining to do, and they may keep their license, but if they get arrested, they're going to have to jump through hoops to keep their license. And number two, they're going to spend a lot of money on legal fees. All right. So what we try to do is encourage it. If you're a colleague, I'm telling you right now, if my colleague Colleen here was struggling, I'm going to say something
Okay.
because she's endangering the patient, she's endangering herself and other staff members. All right. And as a friend, I don't want to see her struggle, right? So if you see someone struggling, make them aware that, it's getting to be noticeable. Okay. Not only that, next one, you'll see, you'll see the changes. You will see changes. It may not happen right away. Like I said, down the line, you're going to see the person become withdrawn. Maybe they're starting to complain a lot, how they hate this place. Okay. They're talking about financial issues. You'll start to see that change. All right. Their appearance is no longer as neat as it used to be. And it just snowballs. So we like to try to, we all want to help that employee out because it's just an employee that has made a bad choice. Okay. And it's hard to dig out. Next. What we work collaboratively. I work with pharmacy staff. I work with nursing because this is not just one person's problem. It's everybody. So it's a collaborative effort on our part to make sure that we're giving you the best possible help available should something happen. All right. Now, like I said, we are nothing. Every Pyxis machine, we have a monitoring system on it. So we do see what's happening every month. Every site has a committee that is going to review. They review, any suspicious activity or any users that appear to be high. I gotta say, 99% of our cases, everything's justifiable. It's all good. It's that 1% that we got to worry about. All right. So we do investigate, and if it comes a time where we suspect diversion, we're going to call you in. We're going to have a talk with you, and if we feel it's justified, it gets escalated up to the executive committee, and from there we're mandated. We are mandated to report it to the DEA and to the B&E. Now, when that gets reported, folks realize there's other agencies that have access to that. You could have the Attorney General's office, you could have the FBI, you could have the Food and Drug Administration, you could have local law enforcement. So we report it, and it has to be done in a timely fashion. So again, I'm always going to go back to EAP. What we want to get that healthcare professional help as fast as we can, because the faster we get them on that road to recovery, the faster we can get them, back on their career. All right. Like I said, it's not going to be easy if you get caught. You're going to jump through hoops and you're going to spend some money. But most of the people, as far as, what I have seen, and there's no guarantee, but, you do the state mandates, you can keep your license. All right. It's not easy. And this is what we are trying to prevent. Okay. Next. Again, if anyone has questions, the reporting. Now, reporting can, sometimes be sensitive. There's so many ways to report it. You can go through the Ethics Point hotline, which is anonymous. That's going to be that comes to me. All right. Or you can go to pharmacy. You can go to your nursing supervisor. There's ways of reporting it if the healthcare professional doesn't, want to get the help. What we want to do then is try to nudge them to get the help. All right. Now, everyone here, myself included, has been affected. I'm sure everyone, or just about everyone, knows somebody that's struggling. All right. Now, look how many people in this room, I would say majority know. And like I said, I saw one of my friends go through probably the toughest time. Not to get too far into it, he was drafted by a professional sports team. Never made it. One injury just knocked him out, and he just couldn't recover from the medications he was put on. Anyone have questions? Anyone need any answers? Hopefully, I can answer most of them. If I can, I definitely have resources that can. So I would get back to you. Any questions? Everyone's good. Everyone knows what to do. All right, folks. Thank you for giving me the opportunity to speak. I'm going to turn it over to Elaine.
Okay.
Hold on.
Okay, everybody, good afternoon. Hopefully you have some lunch, and if not, feel free to get up and get something to eat. Okay, so as Mike had alluded to, drug diversion is a serious matter. It has serious implications to the patient, to the public, to the community, and to healthcare providers as well as healthcare workers. So if there is a suspicion of drug diversion, what happens are there are several ways where an investigation occurs. One is controlled substance transactions not meeting review criteria. As Mike had alluded to, there is a system in place. I believe it's called auditor program, Heliometrics, that every pharmacy has in place that automatically monitors transactions on a monthly basis. They have to have a sample of X amount of reviews that they need to be done, and that would show whether or not they're meeting the criteria during the review. So some of the criteria during the review process is the medication order, the dose, the time when it was given, is there any documented pain scale, how many medications were taken, how long was it given before it was removed from the PICSs, if the patient refused it, did you document it, how long did you document, and so on and so forth. The other criteria where investigation can come in is that the controlled substance discrepancy cannot be resolved. So let me ask this group, when do you do a discrepancy check?
Weekly. Weekly,
Okay, so,
or when you take out a narcotic.
okay. So our policy, thank you, our policy says discrepancy check has to be done before the outgoing shift leaves the unit. Okay, and you know why it's important to do it then and not an hour later when everyone from the night shift or from the day shift is gone? Because if there's a discrepancy, you are not going to be able to resolve it then and there. And we're not supposed to allow people to go home unless the discrepancy is resolved. Okay, so I know it's not practiced consistently, but from now on, now you're aware, and you should really say to your colleagues, oh, by the way, let's do a count or a discrepancy check before you leave. Okay, this way it's easier for you to rectify, to resolve it then and there while they're still here. Okay, the other one is allegation to drug diversion. It, as Mike had said, it could be someone of your peer had said, well, I'm really concerned about my coworker. Okay, there is something going on with her. And it opens a situation where we need to look into it. The other one is attempted diversion, which can be detected through the software in place. Okay, so next slide. So what happened is if there is if an investigation commences, these are the different steps that we take. So it starts at the unit level. So the manager who is on that unit needs to be aware of. If it is a weekend, then whoever is covering your unit needs to be aware, escalate it to the assistant director of nursing on weekends, off shifts. Okay. And then they will have to notify pharmacy. Pharmacy to be notified that there is, investigation, that we cannot resolve any discrepancy. And then pharmacy now is responsible for notifying the site investigatory committee, which is composed of this chief nursing officer, a pharmacy director, the director of quality, advice council center, as well as Mike and his team, corporate security investigator. And then they're responsible for notifying the system. There's a corporate executive diversion committee, which is comprised of senior leadership, like the senior executive, medical director, Maureen White to represent patient care services, again, the chief of quality and corporate director, and so on and so forth. And then based on that investigation, so when the investigation commences, it's a lot of work and time for the manager, myself, director, who I went through this. It is very time consuming. It takes a lot of energy and effort and focus to make sure that we do the right thing to protect the individual as well as the peers working in that unit. So it takes days, not a day, it takes days to finish the investigation. So what we do is we do a root cause analysis. We look at different records, medical record, narcotic the Pyxis record, documentation of the pain scale, whether or not the medication was given timely after it was removed from Pyxis. So if once the investigation at the unit level is completed, now it is shared with the site diversion committee. And then the site diversion committee shares that investigation findings with the executive diversion committee. And they both talk to see exactly, is there a substantiated diversion? Okay, because if there is, now, as Mike had said, the information has to be shared with external agencies. Okay, and there's a report that Mike needs to complete within 24 hours. And there's also a report in writing within 30 days that needs to be submitted to the external agencies. If it is a nurse, it has to be done by, the chief nursing officer, send that letter. And it has to be done it has to be submitted rather to Office of Professional Discipline for Nurses. If it is a physician, to the Office of Professional Medical Conduct. And if it is a pharmacist, to the Office of Professional Board, Pharmacy Board. It has to be done in writing within 30 days. Okay, next slide. So these are some of the things that we as investigators looking into it. Okay, as I said, we're looking at the practice of that individual compared to her peers. So if you have 50 nurses on that unit, you could just imagine you're not only looking for that individual, Elena, who possibly diluted and, took it, but also looking at maybe a week or two or a whole month to see, okay, what was Elena's practice when it comes to narcotics? Was she getting more medications compared to the other 50 peer nurses working on that unit for that duration, a week, 2 weeks, or a month? Okay, was she taking more medication? Was she medicating the patient, only her patients, or was she medicating patients in the other on that unit, even though it was not her patient? So when Elena was taking medication from Pyxis and the patient was refusing, how long before she documents it? Okay, because it has to be a certain time. When you remove the medication, you have to document it was given. But if the patient refuses it because you went to the bedside and the patient's, well, I changed my mind, I don't want to take it. But there is a process that it has to be timely where you have to go back and document that the patient refused. Or by the time you get to the bedside, the doctor said, oh, by the way, I'm changing the order. So there's also a process that you have to go back and document it timely. Okay, so that's one of the things that we're looking at, the number of the BCA compliance compared to your peers. Okay, the number of or percent of medications wasted. Okay, or the number of overrides in the BCMA. So again, as I said, it's a lengthy process because you're looking at the practice of the individual, comparing it with the practice of her peers for that particular unit. Okay, next slide. The other thing too is, as I said, the removals, 30 minutes prior to administration. So that 30 minutes is extremely important, okay? Because during the investigation, we found out that there was one case where it took over 12 hours for the nurse to document that the narcotics was removed or the narcotics was refused, did not go back and document. So that is really an issue where you start asking, where was the medication for 12 hours? It's not documented. So it becomes suspicious. Number of narcotics not wasted with an appropriate witness. And that's the other thing too, is that when you're witnessing, what are you witnessing? So let's find out exactly when you are asked, when you are being asked, I'm sorry to put you on the spot. I like her. She was one of my team members. So what are you witnessing?
You should be looking at the medication if it's a tablet to make sure that it matches what was removed from the patient.
You're also looking at the integrity. Is it really Tylenol or is it potassium chloride? Okay, because there has been situation where they're swapping pills. It was done so brilliantly that unless you really look at the pill packet, you would not know that the integrity was, Was compromised, thank you. So those are the things that if you are assigned to check, especially on Wednesdays, where you do the count, that you're not only looking to make sure, okay, it's 20, but are you looking at every tablet? Is it open? It is not. Is there a tape around it? That if you're really not looking at, you may not realize, okay? The number of telephone orders to address breakthrough pain outside of standing orders. So as a nurse, or if you're, reviewing Elena's practice, what is it that, how many times is she asking the doctor to say, I need an order for X, Y, and Z? Okay, because the patient did not have adequate pain relief. So it's one of those areas that you have to start asking. And then the compliance in documenting pain skill. Very, very, very important. Because again, pain assessment is a Joint Commission standard, okay? Every pain medication, you have to assess the patient before and you have to reassess after. The new policy now, you have 60 minutes to reassess the patient regardless of the intervention you're giving, okay? But part of what we do is you have to go back to days and days and days of documentation as to every single pain medication was the assessment and reassessment, okay? If I'm giving medication and I don't have the assessment or the reassessment, then that is a red flag, okay? Next slide. Okay, in summary, as Mike had said earlier, it is a serious matter. We want to make sure that leadership understands that we do have a responsibility to safeguard the integrity of medication practices. We do have protocols in place, we have policies in place, that we need to make sure that we're also doing surveillance. Part of what we do on a daily basis is that days, evenings, and nights, leadership has to be aware of what the practice on the unit. Make sure that your logs are complete, because again, narcotics fixes needs to be done timely and not the day after. Okay, so observing your peers is also important. That's the only way you can determine if someone is impaired. And you're reporting your peer because you care for her. You want her to get help. It's not about I'm reporting her so she loses her license. So if you experience, if you see, if you hear someone is, different from her normal behavior, it's time to say, okay, I'm really concerned about you. You need some help. Anything we can do to help. Okay. And most importantly is be educated about what is our process, what is our policy, so that if you're assigned to do narcotic check, if you're assigned to witness, that you're really witnessing. Some of our nurses may say, okay, I trust you, I'll just sign here. But the most important thing is, again, you have to inspect, you have to see exactly what you're wasting to make sure you're wasting Percocet and you're not wasting Tylenol or potassium chloride. Okay. Question. I'm going to turn it over to Colleen. I know she was very understanding. We had to switch slides. We have to run to another meeting. For the nursing quality, so for those of you available at 2:00, we have a nursing quality council available on Teams. So thank you again, Colleen. And with that, I'll turn it over to you.
Hi, good afternoon, everyone. Thank you for having me. So today I'm going to go over a few things. So the topics we're going to cover are narcotic waste policy and the procedure overview, examples of actions taken by the Office of Professional Discipline, what it means to count carefully and why that's important, appropriate method of wasting, and documentation practices within the EMAR. I should actually have a number 6 here because I have great respect for my nursing colleagues. I've been here for many years and know a lot of people in the room, a lot of new faces. I see some students here. Every time I give one of these lectures, I ask for one person to tell me that nursing school was easy. I have yet to find that person, or for one person to tell me that the job here is easy. Is there anyone in here that thinks this is an easy job? My track record is standing. So we don't want to lose our license and the potential for that to happen. So my number 6 should be if I can save one innocent person from getting caught up in a bad problem here and dragged into something that is none of their affair, that should be my number 6. So I know we don't often refer to policies when we're working. This is the narcotic policy and procedure overview. So under no circumstance should an RN document in Pyxis that he or she has witnessed the waste of a controlled medication unless he or she has witnessed the entire process and verified that the dosage was correct and the waste occurred. So if you don't do that and something happens, what do you get hit with? A violation of policy. So we already went over what you're supposed to do when you draw it up, and we know that we get rid of the excess narcotic where? In the controlled substance receptacle, which has activated charcoal in it, it deactivates the drug. The importance of that is, I'll tell you, a couple of years ago, we found a nurse face down in the bathroom with a tourniquet on her arm. She would have died had not one of her colleagues walked into
emergency room, stroke emergency room.
the bathroom because she took fentanyl out of a receptacle. So that's why we have those special containers. It's imperative that you use them. So what happens if you don't follow the policy and you do some of these things? You know, you take something out without an order. So anyone can go on the New York State website and look at OPD actions, and even things like a DWI, driving while intoxicated, for a nurse, is on there. You can check out people you knew that had problems. It's all there. It's all public information. So this is an actual case where the nurse had an indefinite suspension, no less than 3 months, and had to go into a course of therapy and treatment until fit to practice. So now she has been deemed unfit. And upon termination of the suspension, 2 years of probation. That seems pretty harsh. What did she do? She took out a controlled substance by overriding the computer system. So, you could do that for IV narcotics here. Supposedly it was for a patient, but she knew there was no water. And if you think this doesn't happen, a few months ago, I had 33 instances where someone in a short period of time removed narcotics and had no water. And when I started to investigate it, I said, I wonder if they're working today. And as I was watching it, the dilaudid number was going down. The narcotics were being removed as I watched the inventory going down, and there was no water. So besides the harm to a patient, because somebody's in an active, busy patient care area now, what happens if that nurse overdoses in the middle of the floor? You don't want to see that happen. You don't want harm to the patient and harm to the person that you're working with, a colleague. I think it's kind of surprising because you work with these people all the time and you may not realize somebody has a problem. So when I first started doing this, the very first time I had to confront someone that I knew for a number of years, I was horrified. I said, oh my God, I'm so embarrassed. I can't believe I have to sit down and start to discuss this now. And then I said, well, why am I embarrassed? I didn't do anything wrong. Now, 20 years later, I see people that I've known for 20 years or more, and nothing surprises me. So you can't just go by the fact like, oh, I've known her for years. I know him. I work with him. He's fine. How many years have I known you, Yvette?
At least 20.
At least 20, right? So if I'm working with a vet and I say, oh my God, Yvette, I'm so overwhelmed. It's so busy. I gotta waste this stupid thing. Do me a favor. Can you just log in? I know you're busy. Just log in. I'm going to take care of it. And Yvette knows me for over 20 years. She knows I'm solid. She puts her finger down. She's busy too. She has no time for my nonsense and my story. And she goes. Yvette doesn't know I actually have a problem. I've been hiding it pretty well. And weeks go by and I'm doing this with other people and everybody's accommodating me. This is great. I'll fill my pockets. And then all of a sudden, pharmacy catches me and they start to investigate. And I see all these wastes occurring. Elena, what happens? What do you instruct me to do? Elena tells me, uh-oh, look at everybody that this person wasted with. Now I'm running their activity. They weren't really doing anything wrong, but they wasted with somebody who has a problem and they don't know that that person has a problem. And guess what? Now they are the focus of my investigation also. And everybody's practice is not pristine. Now we're discovering they're wasting. Now the senior manager is going back, speaking to them. Did you really see the waste? Or did you just put your finger down because you're all rushing? Now they have to start to explain their practice. You don't want to get caught up in this. You have to just try to do the right thing. I know it's busy. I know it's overwhelming. I spend a lot of time down in the emergency department. I know what it's like. You have to scan. People don't scan. I had yesterday, I don't see the manager. Someone had a 20.2% compliance for BCMA scanning, which means they're 80% non-compliant. This is here to save you. It may take a few seconds, but it's a busy environment. You're stressed. If you don't mark that you gave something, it didn't happen. And I'm seeing this. People take a narcotic out. You have a sickle cell patient with very high pain needs. If you forget to scan or whatever causes this to happen, it flags. I see that you removed something, but it never made it to the patient. You might have given it, but you didn't scan, you didn't go directly to the EMR, and so now that dose is missing. So now we get back to the inventory and what it means to count carefully. So from a distance, I know we're doing this because pharmacy does it too. You look down and how many tablets are there? Ruby's saying possibly none, but from a distance, when you're looking down, it looks like one. Okay, next slide. Ruby hit it, none. So in my latest diversion case, which I'm going to be honest, it's with the DEA now. I've had a BNE inspector here working hours. We've worked hours with her and she will be back. And maybe it will go for prosecution. I give kudos to the nurse doing the inventory. I was already investigating the nurse, but when they were doing the inventory, she discovered that a Percocet looked like it had been tampered with. And when I went up to look, it was not Percocet, it was sodium chloride put back in the Percocet packet. So that's a very desperate person. But what happens now? You come and you need the Percocet, you take it out, give it to the patient. An hour later, they're still screaming in pain. Sodium chloride doesn't do too much for pain, right? So when I discovered that, I pulled the machine apart. I called corporate security because what did I find? Oxycodone switched out for Zofran. Oxycodone switched out with Zyprexa. Dilaudid oral syringes swapped out with sodium chloride. This is someone that worked here for a long time that I knew. All her colleagues knew her. And I'm being straightforward and honest. You should know what goes on because you have to be aware of the people you're working with. Trust no one. Your license is your own responsibility. Only you can protect your license. Yesterday, anybody see what happened at Yale New Haven fertility clinic? Tell us.
Basically, they found that the patient, I think they were having is it ovary pain, or they were going in for like
infertility treatment.
Yeah, and they were having a lot of pain, and they were giving them pain medication and through like IV fluids, I guess, and they found out that they were wondering why the patients kept screaming in pain so much. And it turns out that the medication was swapped with, I think, water.
So it was supposed to be fentanyl. 34 women are now suing them for an astronomical amount of money. And the anesthesiologist noticed that one of the caps was loose. So when you're doing the inventory, you have to look at the tablets, look at your vials, make sure that the tops are intact. They actually, sometimes people shoot right through the cap with their needle. Like, you wouldn't think of all this. I certainly did. Unfortunately, now I'm getting an education that I never planned on. And certainly they didn't teach me in pharmacy school. But you just have to protect your own license. You know, it's imperative. You're protecting the patient, a colleague. But to me, the most important thing is your license, your livelihood. Next slide. So we already went over, you know, the method for wasting. If somebody asks you to waste something and you don't see it, don't waste it. Don't waste it. The last case we had, there was some very sketchy waste practices, crushing things that weren't really the tablet. You know, you have to make your best attempt to ascertain that it is what it is. You know, I don't expect you to go to Micromedics and start to look at the numbers on the tablet or call the pharmacy and say somebody's here wasting and is 2154 really, you know, an oxycodone. You just have to visually inspect and make your best effort to make sure that it's the correct thing. So Elena did speak about pain documentation. This is one of the things that I look at, and sometimes you'll see people giving dilaudid for a pain score of 2. They're just filling in the number, like we know that shouldn't be. But the other thing with your license is that if you don't do a pain assessment and a patient comes back and makes an allegation that their pain was not controlled or was not controlled properly, if you only gave an Oxy 5 instead of an Oxy 10 and the pain was 4, not 8, how do you prove that if they make an allegation of pain? Really, you know, they teach us this in school. If you didn't document it, you didn't do it. Documentation, good documentation is your best friend. Poor documentation is going to get you every time. Lack of documentation and going back to document things. So without telling you everything that I look at, the system can actually see how long it takes you to administer something, pre-dating, post-dating, and I will tell you, I'm starting to see a big issue with people walking around with things in their pockets because it's busy, they're overwhelmed. You cannot carry things in your pockets for 4 hours. It's not secure. And what happens is when you start doing this, you'll take a dose out ahead. Oh, I know they're going to need this. I'm already in the machine. Maybe they refuse. You get busy. You forget to give it. People are starting to get a collection of medication in their pockets. Then at the end of the shift, they don't know what to do with it. They don't remember who it came from. They're returning it on the wrong patient. They're going to someone asking them to waste it. So you really have to follow the guidelines and take it out right before use. You can't be carrying a supply around in your pockets. Very dangerous. And I am starting to see that. So what shouldn't you do? No pain assessment, no reassessment, medication not given according to the indication, not documented, documenting without using your flow sheet, retrieving the medication at one time ahead and then documenting much later, documenting early, because we know those little nice FOD labels, you could scan and keep an old thing in your pocket and scan and then give it later, but that tracks because if you gave Percocet now and you didn't remove it until 2 hours from now, that also flags. Bypassing BCMA is never a good thing, and handing off meds. So I know like we're not supposed to do team nursing, but sometimes we do. And I'll tell you, I've had examples here where somebody handed it off and guess what happened? That person had a problem and they did not give it. But if you removed it, who am I looking at? I don't know who you handed it off to. So it's a practice that we should not definitely do. So in summary, count carefully, waste appropriately with the witness, make sure you're witnessing the entire procedure, good documentation practices in a timely manner, and then resolve your discrepancies, report everything. There's this anonymous reporting, and the software is very good. It has helped us find people that are dangerous and shouldn't be practicing, but some of the best tips have come from colleagues that were concerned about people working with them, always asking to medicate their patients. I know you're busy, let me help you. And then, if you see that somebody's just always willing and having time to medicate all your patients, that may be a red flag. They may be wonderful, but it may be a red flag. Other thing I want, Melanie, did you want to say anything? So I'd like to introduce Melanie Galvin, who's from corporate pharmacy and also keeps a watch on things from the corporate level and uses the heliometric software. Did you want to say?
Thank you, Colleen. Yeah, I mean, I think this is a great presentation and like Mike said, Elaine, Colleen, the purpose really is to protect your license and to protect yourself. And the number one thing we always focus on is patient safety. At the end of the day, we need to keep our patients safe and we need to keep our team members safe. So we are looking at all of these things. We're monitoring and we're trying to catch as early as possible. The most important things are to make sure you're documenting appropriately. That's the best thing that you can do to protect yourself. Make sure you understand the policy. There are a lot of policies. There are a few patient care services policies that talk about appropriate controlled substance activity, PCA assessments, and opioid pain assessments. I know the timing is different on all of them. There are the pharmacy and therapeutics policies around the investigation process and discrepancy resolution. So it's a team effort on our part, pharmacy, nursing, security, quality, and I work between the site diversion investigatory committees and the executive investigatory committees. So I've seen all of the cases at the system level. Some of them are very sad, and we do the best that we can to try to catch things as early as possible and to try to help someone much earlier in the process to hopefully save their license. So it is very serious. We do take it very seriously. And I think this was a great presentation to be done at Grand Rounds.
You guys have questions? Is anybody concerned?
I would just like to add that, you know, when we talk about narcotics and people that use, if you ever have, let's say, someone close to you, unfortunately I have, that has been a victim of diversion and unfortunately passed away over a year and a half ago, about a year and a half ago. The kind of assistance that is available, because it's not just the person that is affected, it's the team, it's you, it's your, you know, your loved ones, maybe. So I think like the EAP program is not just for the person, or for reporting. And the ethics committee also, we have a really great one. It talks about moral distress. So these kind of things can also help you. Let's say if you were ever to know someone or have someone around you that is suffering with this, because it's a ripple effect. Yeah.
I just wanted to add, thank you guys for this presentation. I think some of the big things about this also that are included, I heard earlier talking about the ease of this actually happening. Right. So it's about the conversation. Right. And I know that, you know, when you think about it, there's probably a bunch of people in this room who have been touched by somebody, whether it's a loved one or a family member who's had an issue. And it is so easy. Right. You go and get a dental repair, you get an order of Percocet right then and there, you know, and if you've ever been somebody who's ever had pain or chronic pain and have taken those medications and you're like, wow, the pain went away. It's so easy. And I think that that's something that we have to make sure that we continue to have that conversation with our team members, with each other, to make sure we're caring for each other. I'll tell you, when I was a nurse practitioner, one of my rotations was in Southside's ED. And I took care of a patient who was in her 30s who was found unresponsive in a motel parking lot. The person who called 911 was her pimp. And so she had received Narcan in the field, came in and was completely disheveled, you know, someone that you would probably think like lived a very, you know, not purposeful life and lived on the streets and, you know, was getting day by day. When we finally contacted her family and her family came in, she said something, the family member, I remember, said something to me, do you know that she's like you? And I was like, what are you talking about? And she's like, she is a nurse and she had back pain and she got prescribed that and she got hooked on it. And a year ago, she was doing the work that you're doing. And so that to me was a really humbling time, and understanding that, you know, this is really an issue, and making sure that we have the ability and the resources to have the conversation, and that it's okay to have the conversation. You know, I think to the point of, we want to make sure that we have a just culture. We want to make sure that we're doing the right things, but that we're protecting each other, that it's okay to say, hey, is everything okay? And it's misuse and abuse, right? So there could be other cases where I've been involved where it's a family member who's at home who's sick, and that's what they're doing is they are collecting meds so that they can go and take care of their family member. And so having that conversation, so saying, hey, this is something that is detrimental to your license, but also detrimental to the way we care for our patients, but we have resources that can help you out taking care of your family. So just again, I really appreciate the conversation, and I think that that's important. I think that that's another big component of this is having the conversation that it's really easy to have these issues and that, there shouldn't be a stigma behind it, right? Because I think back in the day, diversion was very much that, right? It was like, oh, you're doing it because you're selling it on the street versus that it can be really easily addictive and it's a chemical thing as well. So.
Excellent, thank you.
Do we have any other questions for our speakers? Comments? Don't have anything in the chat. All right, thank you guys.